Hello and welcome again to another edition of the Osteopathic Lyceum podcast. I'm going to look at an article that is very recently in press with respect to when I'm recording this in the International Journal of Osteopathic Medicine. The title is Immediate Effects of 3 Different Upper Trapezius Trigger Point Techniques on Pain Intensity and Pain Thresholds in Students with Cervical Pain, a Randomized Clinical Trial. So long title, being very clear though as to what they were doing and who they were doing it to, or broad strokes, the type of people that one might expect within a group of students, right? Excuse me while I clear my throat. So I'll read the abstract. Now, unfortunately, I don't have access, as often is the case, to the full article. So there's some stuff that I can comment on in a way that lacks accuracy, but hopefully I'm pointing in the right direction when I make commentary. Right, so to read the abstract or to begin, and then there's some other papers or some other information I'll bring in just so that people understand really, really simply, or as simply as I can make it, what I'm attempting to say here. So to read from the abstract. Objective: to compare the effectiveness of 3 manual therapy protocols, Jones, Lewitt, and Chaitow, with a sham group in terms of pain threshold and intensity. So Jones technique, if I'm not mistaken, is the Australian term that is used for strain counter strain from Lawrence Jones, who was the developer of strain counter strain. Now, I'm not 100% sure about that because there's something a little bit later on in the abstract that makes it a little bit more fuzzy for me. So I may be wrong on that. But Jones' technique, as far as I know, is strain counter strain, but I may be wrong. Lewitt, not sure. Leon Chaitow has written osteopathic technical books that I can remember. So I would assume that would be considered an osteopathic method or would fall under that. But I think, what is going on? Yeah, there it is. It's physiotherapy students, so they're learning what would be termed osteopathic systems or osteopathic approaches, whatever that does or doesn't mean. That's kind of where we're at. So to continue to read, the participants, 52 physiotherapy bachelor students with neck pain lasting more than 3 days were recruited. Again, nice and clear, told you the population, how long the neck pain had lasted, 3 days or more, and that's who they were looking for. Outcomes, to read again. Pain was assessed with the numerical rating scale and pressure algometer, while cervical range of motion was evaluated with the BioBit inertial sensor. I may have said that wrong. It's a brand name, it looks like, because it is in all caps. Well, not all caps, sorry. It's capitalized. Each word is capitalized, so I believe that's a brand name. Now, the numerical rating scale for pain, that is a subjective scale. So in almost all cases, it's 0 to 10, and you're going to then measure the so you're going to take the number, you elicit the pain, the person tells you how much pain they feel out of 10 in their own terms, and then whatever your intervention is after that, you redo the same thing and you ask them about the level of pain, and it's going to change in numerical value. You add that all up, you average it out, and you've got a number to show you how much on average it changed. It doesn't show you each data point, but when you aggregate it over 52 people, a larger number would be meaningful. But if you see a relatively small number out of a 10-point scale in, say, real number, even with fractions or decimal points, in terms of real number size, it's a greater effect. If it's a smaller number, even with decimals, it's a smaller size effect as far as a subjective numerical pain scale. Excuse me again, the pressure algometer, and that's where I want to bring in the other paper just to give some background on this. It has been validated, so I'm going to read the title of the paper that I'm using to just quickly talk about this, and the title of the paper is Reliability and Usefulness of the Pressure Pain Threshold Measurement in Patients with Myofascial Pain. Okay, now I don't know how they came to a diagnosis of myofascial pain. I'm not 100% sure how they were defining that, so there could be some stuff to pick at here, but it's just really, really quickly to talk about the algometer. And then, so I'm going to read from this abstract, and then I'll go back to the initial paper. So the objective of the paper that I already noted, reliability and usefulness of the pressure pain threshold measurement in patients with myofascial pain. The objective, to assess the usefulness of a pressure algometer to measure pain threshold, PPT, or pressure pain threshold, PPT, for diagnosis of myofascial pain syndrome, MPS, in the upper extremity and trunk muscles. Okay, so continuing to read. The method, a group of 221 desk workers complaining of upper body pain participated in the study. 5 physiatrists made the diagnosis of MPS using physical examinations and PPT measurements. PPT measurements were determined for several muscles in the back and upper extremities. Mean PPT data for gender, side, and dominant hand groups were analyzed. Sensitivity and specificity of Fisher's standards method were evaluated. PPT cutoff values for each muscle group were determined using an ROC curve. Okay, so you have physiatrists. So the physiatrists determined myofascial pain or myofascial pain syndrome in whatever ways that they would commonly do that, or in some standardized way. Right? So you've got at least got some definition of, or description of how that happened. So the results. Cronbach's alpha for each muscle was very high. The PPT in men was higher than in females, and the PPT in the left side was higher than in the right side for all muscles tested. So I'm going to say that the higher pressure point threshold pain, or the pain pressure threshold, pressure pain threshold, I'm probably missing up the terms. The higher level in males is saying that it took more pressure to elicit the pain in males. That's what I'm assuming, and a little bit less pressure than in females, based on their findings. That may not hold up in all samples. So there may be samples whereby, due to random nature, whatever sample of females versus males that you have, the females may require more pressure than the males. So it just depends on the sample in some cases, but this is what they noticed. No significant difference in PPT for all muscles between dominant and non-dominant hand groups. And for whatever reason, you needed more pressure applied to the right side, or sorry, the left side, than the right side for all muscles tested. So it seems like they're saying the right side takes less pressure to elicit a pain response from the patient. Anyways, the conclusion: the digital pressure algometer showed high reliability. So reliability being you get a consistent range of results, and it discriminates well from pain to no pain is, I think, a reasonable way to say that. So it will clearly delineate those with the pain and those without the pain. So that's the reliability term. So to read that again, conclusion: the digital pressure algometer showed high reliability. PPT might be a useful parameter for assessing a treatment's effect, but not for use in diagnosis or even as a screening method. So at least with respect to effectiveness, there is something here. Effectiveness, for measuring effectiveness pre and post treatment, is what they're more or less saying here. And that then provides an underpinning with respect to, say, the term validity. Is this doing what it says it's doing for the study that we're really looking at? Okay, so we've gone through that pressure algometer piece, the cervical range of motion. I don't know about it, inertial sensor, but essentially what the term inertial sensor is likely to mean is that they're going to have that placed somewhere, and it's going to measure the movement through mechanical force of some form. So I don't know if it is movement from a center point, but there's some mechanical measurement there. So I'm going to read again back from our initial paper. The intervention: an investigator independent of the assessment and randomization conducted all the interventions and sham procedures. Specifically, the Jones group received a pincer palpation with a 1-minute duration of ischemic compression, followed by 90 seconds of the no pain strain cranostrain technique. There it is. Okay, so just to rewind a little bit, when I said Jones technique is strain counterstrain, that's where it is, where it comes up. And the way that I was reading it before is what had me thrown off a little bit. So luckily, I was at least on track. Jones technique is essentially strain counterstrain in Australia, though. So there was a pincer grip palpation with a 1-minute duration of ischemic compression. So I guess that's pinching an area so that it has a lack of blood flow for about a minute, or assumed lack of blood flow for about a minute. And then strain, counter strain. You find the point of tenderness, and then you make that the area where the patient tells you it's tender, you make as many tissues in as many ways around it go soft, and you ask the person, do you feel more pain, less pain? So you give the 1 to 10, whatever, more pain, less pain. If it's less pain, you continue to go that way. If it's more pain, you don't go that way, or you don't continue the movement that you're doing to take tension off the area. The Lewitt group underwent flat palpation for 1 minute, so no ischemic compression, accompanied by 40 seconds of intermittent compression and post-isometric relaxation. So I'm assuming they would compress the area and then have the patient contract an area and relax it. So there was on-off there. The Chitau group received a deep palpation for 1 minute, followed by the pressure release position lasting 20 seconds to 1 minute, concluding with the muscle energy technique. So muscle energy technique, as far as activating forces, the patient activation forces, could be a lot of different things. You could have reciprocal inhibition, post-isometric relaxation. You can have crossed extensor reflex. Probably didn't do that here. You can have respiratory assistance. My assumption is that this would probably be a little bit more direct, is that they would contract into the direction of restriction contract away from the direction of restriction. And when the patient relaxes, you reposition them. It's probably what that is. So there's a decent amount of complexity in the application of these techniques or technical interventions, which is fine because they're following the design of those methods themselves. They're following it in a procedural way, okay? Which matters if you're trying to see if the thing does what it says it does. Now the results, effects for all 3 techniques, Chitau, Lewitt, Jones. So any numbers goes Chitau, Lewitt, Jones, all right? To read again, when comparing them to sham, let me read the full sentence. Effects for all 3 techniques, Chitau, Lewitt, Jones, when comparing them to sham, were not significant on pain intensity. So to read the numbers, negative 0.96 for Chitau, negative 1.01 for Lewitt, negative 0.63 for Jones, or on pressure threshold, negative 0.5 for Chitau, negative 0.4 for Lewitt, and negative 0.19 for Jones. No adverse events or undesirable effects were observed during the study. So essentially on the pain intensity scale, or the numerical pain scale, 0.96, a reduction of 0.96, a reduction of 1.01 on average, and a reduction of 0.63. So really, we're not even getting consistently a reduction of 1 intensity point on a numerical pain scale, regardless of methodology. And I'm assuming all of these methodologies would say that they're there to drop pain intensity. At least with strain counter strain, I can tell you that the aim of strain counter strain, especially because you have the person providing you feedback generally as to whether or not there's more pain or less pain with the movement you're applying to try to take tension out of the area, that the consistent thing would be we're going to drop pain or the sensation of pain. But at least with respect to applying the methods procedurally as laid out, we see minimal impact on the target sensation, which is pain, or on the target report, which is pain. Even on the pain pressure threshold, we see, negative 0.5, negative 0.4, and negative 0.19. The nice thing, no adverse events or undesirable effects were observed in this study. So it did a little bit of good, and it didn't do any bad. So if we categorize how often did this go in the right direction, generally went in the right direction, not with high magnitude. How often did this do nothing? Sometimes. Probably sometimes. I can't see that. But then how often did this go in the wrong direction? And as far as we can tell, never. It didn't really go in the wrong direction. Now, I can't say that for sure because I can't see the full data set, but I can say that no adverse events or undesirable effects. So undesirable effects is probably the term that says the pain didn't go up, right? Or didn't increase in intensity based on the subjective report. So read the conclusion. The immediate effects on pain intensity and pressure threshold are not directly attributable to any of the 3 tested trigger techniques. So yeah, if the trigger point techniques, generally speaking, they're claiming to reduce pain something, right? Now they use 2 pain measurements and they really don't seem to do much to them. Now, if we use medical ethics, right, non-maleficence, then the no adverse events or undesirable effects passes non-maleficence, right? Then we want to go to beneficence. Okay, does it do something positive? Well, I mean, a little bit, but maybe not as much as the patient would hope for. So at least these methods for the target of pain can cross ethical thresholds. They don't seem to cross effectiveness thresholds, but they at least cross ethical thresholds. And then the thing that is probably most important to me is that what we're noticing here, at least within this very, very specific study, is that targeting something on the level of sensation, such as pain, so pain being appropriately classified as a symptom because only the patient can sense it, the practitioner can get information that is likely a proxy for pain. None of it's a good proxy for the actual intensity, location, duration of the pain, but we can at least get proxy information that if there's some form of abrupt response to movement, whether it's a noise, a contraction in a given area, a pull away from the region, something, a facial expression, anything abrupt in relation to motion that you impart to the patient is a likely proxy for what would be termed pain. Now, that may not always be the case, but usually it's a decent proxy. So we can't directly observe it. We can observe it by proxy, but because only the patient can sense it, it would be considered a symptom. Pain is a symptom. Pain is not a sign. A runny nose is a sign because the patient knows they have it and the practitioner knows they have it. Whereas a headache is a symptom because only the patient can identify it. The practitioner can get some information by proxy that maybe something's there, but they have to coordinate with the patient and ask, do you have a headache? And then the patient has to respond accurate to the internal state. So headache is a symptom, pain is a symptom, runny nose is a sign, red eyes, they're probably a sign, but the patient may not be able to identify it. But if the patient has a mirror, they can identify it. So say red eyes would be a sign because both practitioner and patient can identify it under the right circumstances. So hopefully that makes some sense with respect to difference. When you're targeting symptoms, because you can only at best get information about them by proxy, you're going to have a hard time getting them to change consistently in the direction that would be desired. It doesn't mean it can't happen. It means it's hard because it's an obscure measure or it's an obscure phenomenon to you as the person who's going to be interacting with somebody else. With respect to observations that have been made through thesis projects and thesis experiments by members of the Osteopathic Lyceum, what we seem to be noticing is the similar thing. If you try to target things that are obscure to the observer, right? Physiological measures, sensory measures, how often does pain match up with mechanical finding? There are differences here. They are not consistent things. So they can't be considered highly trustworthy things to target with manual interventions. It's not that we won't benefit them. It's that we have a hard time identifying them properly, to target them properly, and our interventions, as is seen with this paper, don't seem to hit it right. So we have another piece of information that increases confidence in the claim that attempting to target subjective measures with hands-on manual therapy is not an accurate, easy thing to do. It's a very hard, very inaccurate thing to do. But if you target movement restrictions, either in the form of large macro movement restrictions or in terms of lack of yield to pressure in soft tissue, so you squish a soft tissue and it doesn't squish, if you target those things, because they're obviously not moving, they're observable outside the patient, we can probably have a positive impact there. It then ties back into the classic Dr. Still quote, or the Still attributed to Dr. Still, the quote attributed to Dr. Still of find it, fix it, leave it alone, and nature will kindly take care of the rest. Another way to say that is, if the mechanical dysfunction that I find is properly related to the internal sensation or the internal state that is being presented, if they're properly related, if I deal with one, the other one will change. So if I get you moving better, the ouchie will change to some degree. If they're not related, I'll get you moving better and the ouchie will be exactly the same. So another piece of information that does seem to raise confidence that if you're targeting subjective measures, you're probably going to miss the mark. You're not going to have the desired impact. And my suggestion is that it's primarily because you can't observe it properly. You can get proxy information about it, but you can't feel what they feel. So you're probably going to miss more often than not. But if you target movement, you're probably going to accurately have improvement more often than not. And if the movement restriction is properly related to the internal sensation, they'll change together. If it's not, it's differential diagnosis through treatment. So hopefully you listened this long, hopefully you learned something. Thank you very much. We'll talk again soon.